Welcome to the Midlife Wellness Podcast. I'm Kim Hefner, a family nurse practitioner, menopause specialist, and your host of the podcast, where we dive deep into the multifaceted world of midlife and menopause. I am passionate about helping women optimize their health and hormones in midlife and beyond. On this episode, I had the honor of hosting Dr. Eric Balcavage, a distinguished figure in the field of functional medicine and thyroid physiology. With over 2 decades of experience, Dr. Balcavage has positively impacted the lives of thousands suffering from thyroid and chronic health conditions. As the owner and founder of Rejuvigen, his commitment to staying at the forefront of healthcare and science has earned him global recognition as a leader in his field. During our conversation, we delved into the complexities of thyroid disorders, addressing root causes, managing insulin resistance, autoimmunity, inflammatory concerns, and the unique changes experienced by women in midlife and menopause. Dr. Balcavage's wealth of knowledge and expertise provided our listeners with invaluable insights into navigating these critical health challenges. To learn more about Dr. Balcavage, his practice, go to rejuvigencenter.com and follow him on social media at Dr. Eric Balcavage. You can listen to the Midlife Wellness MP podcast on most podcast platforms and find me on YouTube. Thank you for being here and enjoy the episode. Hi, everyone. Welcome to the podcast. Today, I have Dr. Eric Balcavage on. He is the owner of Rejuvigen. He is a leader and expert in functional medicine and thyroid health. So welcome, Dr. Eric. Welcome to the podcast.
Well, thanks for having me.
I'm really looking forward to this conversation. And I just want to real quickly just learn a little more about you and your background and what you've got going on.
So originally I started as a chiropractor, but due to different issues that came up in my family's life, my patients' lives, and my own life, I switched from chiropractic care back to still did chiropractic, but I started doing functional medicine, and that has become the focus of what I do now. And I've been doing this 28 years and helping people recover their health. I talk through the lens of thyroid physiology, but that's not really what I do. In functional medicine, our goal in functional medicine is to identify what's causing the body to behave a certain way, determine if that's dysfunction or adaptation, and then address the actual root cause. And that's what I focus on doing. A lot of the people that come to see me are patients that have hypothyroidism, whether they know it or don't know it, but most of them come because they have hypothyroid signs and symptoms, whether they're on med or not on medications, and don't feel well. And if they're not on medications, they think they have a thyroid condition, and their primary or their endocrinologist has said, TSH is normal, free T4 is normal, you don't have a thyroid condition. And for the other group, that's the group that's on medication, regardless of whether they're taking T4, combination of T4 and T3 only, they still don't feel well and they're frustrated. They can't figure it out. And I think, philosophy from which I work from is what allows me to help a lot of those people who are frustrated in both the allopathic and functional medicine models feel better on less medication. And for many of them over time, they wind up not needing their thyroid medication at all. So that's what I do. Help people get themselves healthy.
I was going to actually ask you that a little further down, if there's a chance people can actually get off their thyroid medication. I've had quite a few patients say, I really don't want to take it at all. And so I was actually going to ask you, do you have patients that you've been able to get off of thyroid medication completely?
Yeah, lots of them. I think there's 2 categories of people. There are people that are on thyroid medication and didn't have any business being on it to begin with, but somebody did it as a way because the patient was complaining, they look hypothyroid, they felt hypothyroid, their labs were normal, but they said, you know what, we'll just give it to you and see how you feel. And they felt better, at least temporarily. And so now they're on this roller coaster of taking thyroid medication. And they probably shouldn't have ever been on it to begin with. And then there's the other group of people who are way over medicated, and maybe they're taking just way too much medication. And for those people, they can come off medication. They can definitely, if we address the real root issues, then oftentimes most times they need less medication. And then in time, if we're addressing the root issues, their thyroid gland, as they're reducing the dose, their thyroid gland can start to recover. It can start to do the work it's supposed to do, and they can come off medication. That may take longer for those people because they may have been on thyroid medication for an extended period of time. They may have had a lot of atrophy of their thyroid gland, but in general, the thyroid gland can recover. I've even had clients who have had thyroidectomies because of thyroid cancer or other abnormal biopsies, had radiation, had their thyroid gland removed, and were able to come off thyroid medication. So how does that happen? Well, it happens because the thyroid gland has the ability to regrow and regenerate, and it did for these people. So the important thing for somebody to understand, though, is if you've been taking thyroid medication for a while and your gland has been atrophied and hasn't had to work for an extended period of time, it may take time to be able to come off medication. Oftentimes you have to slowly titer it down as you're addressing some of the root issues and allow the gland to recover. If you've been taking a day's worth of thyroid medication as T4 and maybe some additional T3, and you've been suppressing the gland function for an extended period of time, and you just take that away, you're probably not going to feel good because thyroid gland hasn't had to work an extended period of time, and it's going to take time for that tissue to rebuild and regenerate.
So when you've had a patient that's been on T4 alone, monotherapy, for a long time, they come to you, they're still having symptoms of hypothyroidism. They're on T4, say they're maybe in their 60s. I've been a little nervous to change that up or add T3 or change to a combo and some have had their thyroid out. What do you typically do in that case? I always worry like heart issues, it's going to be too much.
Well, I think for every case, it's an individual case. We need to assess their labs based on the medication they're taking. So we need to do a more comprehensive thyroid panel than traditionally gets run. We have to do a good job of interpreting those thyroid panels. And oftentimes when somebody who understands thyroid physiology and the impact that medication can have, we can look at a thyroid panel and you can see that the person isn't converting T4 to T3 at cell level. And so for those people, more thyroid medication is not going to help them. Okay. Mm-hmm. And so for a lot of people, if they're over medicated, it could be one of the best things you could do to help them feel better. Because if somebody's taking a lot of more T4 than they need, and they're suppressing their TSH below 1, that is going to result in a reduced conversion of T4 to the active form, T3, that actually does most of the work at the cell and tissue level. So what happens to a lot of people is they get thyroid hormone replacement. It's typically T4. The doctor is trying to drive TSH into a certain range, and a lot of doctors have different ideas of what that range should be. Some think it should be under 1. Some people think it should be non-measurable. Some people want to see it between 1 and 4. Some people just want to see it in the lab range. But what we need to do is we actually can't just look at labs and see if they're an H or an L on the lab report. We actually have to interpret them. So we look at a TSH. What range is it in? Then we look at T4, T3, free T3 to see what those values are. And then probably the most important thing to take a look at, even if all the labs are normal, is the free T3 to free T4 ratio, which is the indication of how well T4 is converting to T3 at the tissue level. And that tells the story of whether somebody needs less medication or more medication, or the dose is right for now. And then the second step is to look at the rest of their blood panel, which rarely ever gets done by maybe an endocrinologist. They're typically only running a TSH and free T4. And you want to see, even though these thyroid panel values look like they're in the normal range, or what we would say in functional medicine, the optimal range, which may not be optimal at all. We want to look at the tissue impact of those values. So if somebody is taking thyroid medication, T4, and then they've taken some T3 to try and normalize T3, and it looks good. Like some people say, oh, we have to optimize T4 and T3 levels or T3 levels or whatever with medication. And they've optimized it, but the person still has glucose resistance. The person still has elevated lipids. They have reduced cortisol production. Their liver enzymes are dysfunctional. Their renal function's downregulated. Their creatinine levels are low. Then it may be optimized in the blood, but it's not optimizing the tissue level. And so the treatment strategy needs to be changed if our goal is to actually help the client feel and function better.
I think that's a big difference between allopathic medicine and functional medicine. Allopathic medicine, I feel like they're so limited in their toolbox or what they can use or how they ever really know what's actually going on as a root cause of the condition or what's triggering the hypothyroidism in the first place. And I always wonder why a TSH is typically only done with the T4 when it doesn't really talk about what you were just talking about. I explain to my patients the brain may be communicating with the thyroid, but the cells are not doing what they're told. They're not listening to those messages. So when you're evaluating a proper thyroid panel, which labs do you include? Do you feel like is enough to evaluate thyroid function? Do you do an anemia panel, iron panel? What all do you, when you're trying to get that whole picture of what's going on?
So yeah, a couple things there. I think from an allopathic medicine standpoint, they only run a TSH with free T4 because their job is different than ours. Their job is to wait until the thyroid gland has lost 90% of its function and then replace the T4 that the gland can't make. And they've been taught that as long as they normalize TSH with T4, they've done their job. They've given back the thyroid hormone that the gland is not making, and it should work if we put it in there. And the assumption, for your listeners, they're making an assumption that the body's in homeostasis. So cells are like people. We typically operate in one of two modes. We're either in homeostasis, low stress state where we have enough energy to do all the things we need to do in the body, make hormones, make proteins, make neurotransmitters, make skin, make hair, great digestion, burn fat. We've got enough energy to do all this great stuff. It's called homeostasis. And if a person is truly in homeostasis and their gland gets destroyed, we can talk about why it was destroyed, immune, surgery, radiation. The only problem was the gland was destroyed. Everything else works because the person's in homeostasis. Then, yes, you could give them T4 and they should feel fantastic. Okay? Yeah, the thyroid gland does make some T3, maybe 5 to 10 micrograms per day, but the bulk hormone that's made by the thyroid gland is T4. So they make the assumption that the person's in homeostasis, and if I just give it to them, it's going to do what it should. But people that have chronic health issues, that have thyroid issues, that have immune, they have inflammatory issues, they have weight issues, aren't in homeostasis. They're in a different state we call allostasis, which means I'm under stress. I don't have enough energy to do everything I need to do. I'm going to turn off the less important systems. I'm going to turn down my energy drive to GI tract because I don't need to eat food while I'm being chased by the tiger, right? I'm going to downregulate my sex hormone regulation because I don't need to stop and have sex if I'm being chased by a tiger. I'm going to downregulate sleep cycles because if I'm being chased by a tiger, I'm not going to take a deep sleep nap. So the less important systems get downregulated. We don't feel good when that happens, but that's adaptive physiology. And most of the patients that have chronic health issues, that have thyroid issues, are in allostasis. They're in danger mode. And so we can't assume that these people are going to use the hormone just because we fill the tank up doesn't mean it's getting used. Do you have kids?
Yeah, I have 4.
Okay. So you have kids. Is there ever been a time when you wanted your child to clean their room, you sent them to their room, and you went up there an hour later and nothing was done?
For sure.
Well, why didn't they do it?
Right, right.
Right? Because they didn't want to do it, right? So cells get to determine what happened. We think the cells are broken. The cells aren't often broken. The cells are saying, listen, I'm threatened. I'm not bringing more glucose into the cell. I'm not turning on the metabolism. I'm not bringing more amino acids in and making peptides, because if I'm the cell and I bring more nutrition in and I make more good stuff for the cell to survive, there's a bacteria, a virus, an organism inside the cell. Guess what that organism uses for fuel? It uses all those resources I brought in. So there is a hypothesis called the cell danger response, which incorporates a whole bunch of different actions that happen when a cell is threatened. And that's the state that a lot of our people, and they're in this cell danger response. And that when a cell's in a cell danger response, it turns down manufacturing and it ramps up defense. And we assume that that's broken physiology, but more than likely, at least at the onset, it's not broken physiology. It's an adaptive response to not increase potential compromise of the cell. And so for a lot of people in a lot of physicians in allopathic medicine, they weren't taught that stuff. So they just assume if I give it, it's going to work. And if I give enough to suppress TSH, that means if the brain has been satisfied, all the peripheral tissues have been satisfied. But the problem with that is that the cells and the tissues in the periphery away from the brain regulate thyroid hormone differently than the brain does. So under stress conditions, the body increases conversion of T4 to T3. And in the periphery, under stress, the body downregulates the conversion of T4 to T3. So the systems don't operate the same under a stress mode. And so I understand why they do that, but it's a flawed thought process. Now, the medical community used to look at more than just a TSH and a free T4. They actually used to look at reverse T3 and say, oh, maybe we can use this reverse T3 to determine how much T4 we need to give. Then they couldn't figure it out because it wasn't consistent between clients. Some people felt they'd give T4. The thought process was, I'll give enough T4, and when reverse T3 goes up, then I know I've given too much. But they were giving people T4, and they still felt hypothyroid, and they had elevated reverse T3. So they couldn't figure out what to do with reverse T3. So they said, screw it. We're getting rid of it. We're not going to look at it. If we don't look at it, we don't have to worry about it. Why don't they do T3? Because they found out the same thing. As you increase T4, you actually reduce the peripheral conversion of T3 especially if they're in allostasis. And so it couldn't work. So what do? Let's just not look at those. We'll only look at these two markers. If I give T4, we know TSH should go down. Problem solved. I've done my job. And that's their job. And so I used to bash the community because I thought, wait, how can you be so short-sighted? How could you be so naive that this is the way it's going to be? But I realized that's what they're taught. They've been teaching that for 20 or 30 years. And why do they do that? It's because it's the way they do it, right? And I won't get into the politics and the money involved in that, but that's the way it's been. I don't think it's doctors trying to not help people. I just don't think they have any clue as to how thyroid physiology actually works. But I don't let the functional medicine community off the hook either, because I think in the functional medicine community, we think we do it better because we run a fuller thyroid panel. We run a TSH, total I'm not even seeing that anymore in functional medicine. But what I look at is a TSH, a total T4 and a total T3. You'll see a lot of functional medicine practitioners not running free T total values anymore. They only run free T3, which to me is ridiculous. But then they'll look at free T4 and free T3. And if they see that free T3 is low, they'll probably run a reverse T3. If they see free T3 is low or total T3 is low and reverse T3 is high, they'll say to their clients, your problem is you're not or can't convert T4 to T3. It's being converted to reverse T3. The reverse T3 is a mirror image of T3. It's going into the cell and blocking T3 from binding. Therefore, what we're going to do is we're going to give you T3 and we're going to give you more and more T3 so that we suppress reverse T3 and then you'll feel better. And the problem with that thought process is it's wrong. So the assumption is that the body somehow one day woke up and forgot how to convert T4 to T3. And that's not typically correct. There are some people that have a genetic polymorphism of the diagnose 2 gene that converts T4 to T3, but that's not the main reason that people are not converting T4 to T3 and they're increasing their conversion to reverse T3, which is the less active form. And the primary reason for that is inflammation and cell stress. And so if a cell's stressed, it's going, hey, I don't want to increase the metabolism. I'm going to use this other enzyme, diagnose 3, deactivate the T4 to reverse T3, which for the most part isn't happening inside the cell. It's happening on the outside of the cell. And we're going to get rid of that T4 so it can't increase conversion. And so the reverse T3 isn't a mirror image of T3. It doesn't really bind to any significant level to the nuclear receptors or the mitochondrial receptors. That's been shown that it doesn't do that. So that story has to go away, but that's being told. And then in functional medicine, we say, okay, I'll give you 5 micrograms of T3. You're probably going to feel better. And they will. They'll feel better temporarily because that T3 has an easier time getting into the cell and can get to the receptors and they might feel better. The problem is the same enzyme that was deactivating the T4 to reverse T3 is still there, still being made, and it's going to deactivate T3 as well. And that T3 can be deactivated to T2, which nobody measures. And there's a couple different forms. One form is viable. The other 3 are not. And so they feel good temporarily, and then they plateau again. So then the doctor says, well, then we'll just give you another 5 micrograms. And they feel good, and then they plateau. And then they take another 5, and they take another 5. And it's like putting somebody on heroin, and they're chasing the high that they can't get. And then they wind up on these really high doses of T3. Yes, their reverse T3 goes down because they've suppressed their TSH with the T3. They've essentially turned off the thyroid gland's ability to make any thyroid hormone at that point. They're now an addict to T3, and there's not enough T4 in the system to do some of the things it needs to do. And now the person is taking higher and higher doses of T4. Maybe they get frustrated and they're going back and adding T3 and T4. They don't feel well. And why don't they feel well? Because the same root issue is the same. The cells are in a stress mode. They don't want to increase the metabolism. So trying to force the chemistry is ridiculous. So when we look at somebody and want to assess their physiology, we can't just run thyroid panel. We have to run that full thyroid panel, TSH, total T4, free total T3, free T4, free T3, T3 uptake, thyroid antibodies, although what people think thyroid antibodies mean is probably not correct either. But that's just the start. Then we have to look at the rest of labs, at least one tissue indicator of how thyroid hormone is doing at the cell level. But I typically run that. I look at the full thyroid panel. I run as an initial panel. I'll look at probably 8 or 9 inflammatory markers because inflammation is the big driver down regulating conversion. So you would need to look at inflammatory markers to find out, is the reason their TSH is suppressed, or is the reason there's reduced conversion of T4 to T3 or increased reverse T3 because there's an inflammatory process? And if there is, the root issue is identifying what's driving the inflammatory process. But then I typically look at blood glucose markers, liver markers, renal markers, GI markers, malabsorption markers, vitamin Ds, both of them, and look at a my initial panel is typically about 65 tests in a urinalysis. I want to take a broad view of what's going on. So I want to see the big picture and compare labs to signs and symptoms, the history, to timeline, and then make a decision what's going on here. And that's what we call lab interpretation, which really doesn't get done very well, in my opinion. We do a lot of reading labs. In allopathic medicine, it happens all the time. If there's no H, no L, we assume it's good. In functional medicine, we say if it's not in this optimal range, then it's a problem. And that's not always the case either. A lab value could be normal and appropriate. If you feel and function good and your lab value is normal, maybe it's appropriate. But a lab value could be normal and totally inappropriate. If you had hypothyroid signs and symptoms, hair's thinning, right? Overweight, tired, fatigued, constipated, depressed, you got all the signs and symptoms of hypothyroidism, but your TSH is 0.75, somebody might say that's normal. But I would look at that and say, that's not a normal value for the person that's not an appropriate value for the person who's sitting in front of me. So that's where we look at the rest of the panel to say, what would suppress that? Is it their medication? Is it inflammation? What might be suppressing it? Because even though it's maybe considered by somebody's standards normal, it's totally inappropriate. And then the other things we can see is we could have an abnormal lab value. If you said, listen, I think I have hypothyroidism and your TSH is abnormal, it's abnormal, but it's appropriate for you. It's great, right? It's appropriate. It doesn't mean that you feel good, but it just means that the labs kind of match what your symptoms are. So that would be appropriate. And then you could have an abnormal lab value and it's totally inappropriate. And that would be like the person who comes in, listen, I'm totally healthy. I do everything right. I want you to take my labs and show me how great I am. And you get their labs back and their high sensitivity CRP is 45. And you're going, yeah, that's not good. We're going to run that one more time. And if it's high again, we're sending off to the oncologist to get a more thorough assessment. And they're like, what do you mean? I'm like perfectly healthy. You may look good. You may feel good. That marker is indicating that there's dysfunction. So that's an abnormal marker and it's inappropriate for how you feel and function. And that's a huge warning sign that we may have to look for something more sinister.
Right. I was going to talk to you about the reverse T3 because, it's been kind of like, you don't need to check it. It's not really doing anything. But again, to me, it's just kind of a warning sign that something else is going on that needs to be looked at. So it may not be that to me is the point of checking it. It's like, what's sending you clues as to look further as what's going on? Is it toxins? Is it stress? Is it something else? And in regards to the T4 medication, sometimes people just keep upping the dose. What would be the detrimental effects of having maybe overdosing or overprescriptions of T4 or higher doses than needed, like long-term health effects of overprescribing?
Well, so number one, if you over medicate with T4, you're going to activate the sympathetic nervous system. And so for the listeners, we've got, two broad parts to the nervous system. We've got the sympathetic nervous system, which is kind of our fight or flight system. And we've got our parasympathetic system, which is kind of our rest and digest system. And they work back in conjunction with each other. But if one's if you dial up the sympathetics, you're going to turn down the parasympathetics and vice versa. So if you flood the system with too much T4, you're going to create a more hyperthyroid state in the brain. You flood the hypothalamus. When you saturate the hypothalamus with T4, it converts to T3. That drops something called TRH that suppresses TSH. Now the gland is not going to do much work. And some physicians may say that's good. The problem is it can also activate the sympathetic nervous system. And when it does that, that can create signs and symptoms we don't want. If your sympathetic nervous system is chronically upregulated, you're not going to sleep well. You're going to have more anxiousness, more anxiety, brain fog, fatigue, histamine-related issues. You're going to have decreased gut function and gut physiology. Your digestion is going to go downhill because your sympathetic nervous system is activated. So that's one. Two, and the one that really concerns me the most is that let's go number two is once you start flooding the system with too much thyroid hormone, excess T4 in the system triggers the deactivation, or what we call ubiquination, of the enzyme that converts T4 to T3 inside cells. So essentially, too much T4 in circulation then signals the cells that we're in a hyperthyroid state, so the cell stops converting T4 to T3 inside the cells. So by giving too much T4 to try and increase metabolism, you increase it in the brain, but you decrease it in the body. And this is why people on too much thyroid medication are still gaining weight. They're still glucose resistant. They're still having all the same issues because you've over medicated them. And the third one, which is the one that concerns me the most, is that we talk about T4 as an inactive hormone, but it isn't an inactive hormone. T4 can bind to receptors on the outside of cells. They're called integrin receptors. And these are especially prominent on cancer cells. And so if we have a sick cell or an abnormal cell, normally what the body does is says, whoa, we've got some abnormal cells developing. Let's slow down the metabolism so the sick cell doesn't replicate. If the sick cell replicates, we typically call that cancer. And so my concern when I started to learn what these integrin receptors do and that T4 can bind to those, I was thinking, man, maybe if you go with the premise that decreasing the conversion of T4 to T3 isn't broken physiology, but adaptive physiology due to some type of stress response, if the cells and tissues don't want it, the thyroid hormone, they don't want to increase metabolism, but we force thyroid hormone into a system that does not want it, that might mean that we might start replicating abnormal cells. And is it possible that that might increase the risk of developing stuff like cancer? And I said to my co-author and my friend, Dr. Kelly Halderman, before we wrote the book, I'm like, look, this is my hypothesis. This is what I read. I wonder if anybody's ever done a study to look at the rates of cancers in people who are on thyroid medication. And we both agree that nobody would ever pay for that study. Good news was in 2019, somebody did do that study and found that, wow, the incidence of a lot of cancers is increased in people 5 to 10 years after taking thyroid medication. And more papers have come out since then to say hypothyroidism is a protective response against many forms of cancer. So it is a huge concern for me that we are just blindly dumping a whole bunch of hormone into a system, just assuming that it's going to do what we want it to do. And maybe we're increasing the risk of a whole bunch of different cancers in people, but nobody's paying attention to it. I don't think that paper ever got any press at all.
Wow. That's huge too. Wow.
Mm-hmm.
Well, another thing that I check a lot on my patients is the MTHFR gene variants. And I would just wonder, I see it positive a lot, either one variant, two variant. There's, obviously there's multiple variants. I try to explain this concept to my patients and why I'm checking it. But how does having this gene variant impact our thyroid and methylation in general? For methylation, how does that impact thyroid and other things that we may be dealing with as women, such as estrogen dominance and that type of thing?
Well, there's some complication to that. So if we just kind of simplify down, we think about MTHFR, and it is a really common gene polymorphism. And so your listeners, you've probably talked about that maybe on the podcast before. We all have genes. We get a gene from mom, we get a gene from dad, and then we have, and when we have what the most common form is, we call that the wild type. That's the most common form. And then if there's a change in what we call the amino acid sequence of that gene, we call that a polymorphism. So maybe we're going to make up a number. Let's say a gene's got 10 amino acids. If we change one of the amino acids and put something else in there, now that gene may or may not, depending on where that amino acid was changed, may or may not influence how that gene functions. And we've got Everybody. We've got hundreds of gene polymorphisms when we take a look at broad genetic panel. MTHFR is one of them. And I think it's worth taking a look at, but I think it gets too much press all by itself because people then think they just have to take methyl donors if they have an MTHFR polymorphism. The problem is that many times for every polymorphism that we have somewhere in a pathway, there may be another polymorphism somewhere else where the body has made an adaptive change. And so just because we see a polymorphism doesn't mean we have to rush in and do something. In the case of the MTHFR gene, that MTHFR essentially is we get dietary folate, and then we run folate through what we call the folate cycle, take it through different forms. Eventually, we get this form called a methylated folate. And we need this enzyme, and gene and enzyme, the MTHFR gene and enzyme, to help with what we call the methylation process, to add a methyl group, which is a carbon and 3 hydrogens, to this folate group so that we can then use it to do the next step in the process. And so that gene is just one step in the process. I think it's good to take a look at, but it doesn't work by itself. And many times just adding more methyl donors, B12, methylated B9 to a system does not mean what we want to have happen is going to happen. And we often talk about methylation, and we need to give methyl donors because methyl is so important for detoxification process, for energy production. But we also use methyl donors to turn off gene replication, right? So when genes are wound up in these tight ball, and when we methylate the genes, we turn them off, and we use another acetylation kind of unwinds those so that they can then replicate. So I'm always a little bit concerned when people just willy-nilly methylate things. But what is really important and the tie to potentially thyroid physiology is you need appropriate levels of T3 to support the methylation process. And so if you're a person who's got cellular hypothyroidism, meaning the blood could be good, the gland could be good, you could be taking appropriate medication, but inside the cell is actively reducing the conversion of T4 to T3, you should expect the methylation within that cell is probably going to be downregulated, and more B12 or more B9 in that situation may not have the intended effect, and it may leave more methyl donors out there that might become more problematic versus more beneficial.
Okay.
I'm not sure if that's the answer you're going for.
No, that's fine. And speaking of estrogen, I had a patient, and you may know this or not, but you talk about she's having all these menopausal symptoms, hot flashes, and all these other things, and her estrogen levels are low. But when I wanted to, start hormone replacement therapy, she told me she was talked to by a thyroid or whoever's treating her thyroid that she has way too much estrogen in her thyroid gland. So
in her thyroid gland?
So she said, no, I can't take estrogen because I've had too much in my thyroid gland. That's the way she described it to me.
Yeah, I would say that was either the person who said that maybe doesn't know what they're talking about, or it was miscommunicated somehow. So one of the things we think about estrogen, right? We think about estrogen excess, estrogen dominance. We think about how we metabolize it. Getting estrogen generated also requires some thyroid hormone to help support the production of it. And we could talk about that, especially in somebody who's menopausal, postmenopausal. Where's the estrogen coming from? And we can talk about that and the significance of thyroid hormone. But when we think about estrogen too much estrogen in the thyroid gland? I don't know that that's the case. Excessive estrogen can have an impact on iodine getting into the thyroid gland. Estrogen can have an impact on increasing binding globulin, so there's less free hormone available. But I don't know that I've ever seen, read, heard that the estrogen is going into the thyroid gland and shutting down function. I've never heard that. So I don't know where that came from.
I hadn't either. And I just had this picture of it being trapped in the thyroid gland. I'm like, well, you're still having all these symptoms and you would probably benefit from some estrogen therapy. But that's why I wanted to ask you, because I hadn't either.
I would say that for postmenopausal female, or, they're through that stage of life where their ovaries are doing all the work for estrogen, where is estrogen coming from? In that stage of life, we really have two primary sources. One, adipose tissue, and the other one would be the adrenal gland. And it's not unusual to see people with what I call cellular hypothyroidism not be able to generate appropriate sex hormones, right? And so for the listener, when you ask your medical doctor, do I have hypothyroidism? They're thinking primary hypothyroidism, where the gland has become damaged or destroyed or atrophied and it can't make it. That's what they call hypothyroidism. What I call that glandular hypothyroidism. But really what I'm working with most people with is what I call cellular or tissue hypothyroidism, meaning there's not enough T3 inside the cells at the receptors. And regardless of whether you have glandular or cellular, the reason you have hypothyroid signs and symptoms is because there's a decreased amount of T3 inside the cell. You can have a perfectly functioning gland, the appropriate amount of T4 and T3 in the bloodstream, but not enough T3 at the receptors, and you're going to have symptoms. You could have no gland at all. We give you T4 and some T3, and you can have perfectly functioning physiology because there's enough getting to the cells and tissues. So cellular hypothyroidism means, or tissue hypothyroidism, those terms are interchangeable, is that for some reason you have signs and symptoms of hypothyroidism impacting different cells and tissues because the cells and tissues aren't converting T4 to T3 the way we want them to because of that stress response. Or you have glandular hypothyroidism, the gland can't make enough, there's not enough in the blood, and therefore there's not enough in the cell. But fixing glandular hypothyroidism doesn't necessarily fix cellular hypothyroidism. And I'd argue that hypothyroidism doesn't start when the gland becomes diseased and TSH is high and free T4 is low. You probably know this already, but by the time somebody is diagnosed with primary hypothyroidism, they've lost 90% of the function of the gland. They may have been feeling hypothyroid signs and symptoms for decades because cells have been under stress. They're deactivating T4. We're not getting enough T3 in the system. So they could be complaining of hypothyroid symptoms to their doctor for decades, being told there's nothing wrong with you. You just eat too much. You don't exercise enough. You're just depressed. But meanwhile, they've had this cellular hypothyroid state going on the whole time. It doesn't mean they needed medication. It means they needed somebody like you or I who practices functional medicine that's going to say, okay, the gland's still working. There's enough in the blood, but it's not translating to the cell level. We need to figure out what's causing that. So that's that kind of glandular versus cellular. Regarding sex hormone production in the second phase of your life, your adrenal gland is doing like the heavy lifting to make your androgens and estrogens. And you don't need the same amount of estrogen you did when you're 18, when you're 50. I think if the body really needed the sex hormones of an 18-year-old when you're 50, when you're 60, it would do it. You don't need it. And it's probably problematic. Okay. But how is it made? Well, how the adrenal gland, which is the little gland that sits above your kidneys, makes sex hormones is that cholesterol from the bloodstream and we have HDL, LDL, these different lipoproteins. The lipoproteins can dock to the adrenal gland and deposit the cholesterol into the cells of the adrenal gland. That docking mechanism requires T3. So if somebody has insufficient T3 at the adrenal gland, they're not going to be able to pull cholesterol out of the bloodstream to bring it into the cell so they can make sex hormones. The other thing is, how does that inside the cell, how's that cholesterol then made into sex hormones? Well, that cholesterol has to go to the mitochondria and be converted into pregnenolone. And what do you need for the mitochondria to be uber functional? You need T3 inside the mitochondria of the adrenal cells to convert cholesterol into pregnenolone. So if the person has a chronic stress response, reduced conversion of T4 to T3 that's impacting the adrenal gland, they're going to have reduced androgens, reduced estrogens, probably reduced progesterone, probably reduced salivary and urinary cortisol, but their blood cortisol will probably stay stable, which is why I think there's always an argument between the purists who say we only need to check it in blood and it's always normal, so there's never a problem, and the people that do urine and saliva tests who say, no, this person's in adrenal fatigue. A, they're not in adrenal fatigue, and B, the likely reason why the blood levels are still normal, but the salivary and renal and the urinary levels could be low is because the adrenal gland has the ability in acute situations to make its own cholesterol. So even if there's a low T3 state, the adrenal gland has the ability to generate a certain amount of its own cholesterol, make its own, and then convert that into cortisol to sustain function. So there is always some backup system that's going on.
Right. Yeah. I'm big on supporting the adrenals, but I'm also big on supporting mitochondria health in general. And it's interesting when you're looking at all these things, some of the same things that you need to be doing support all of it, getting your sleep, following your circadian rhythm, exercising, decreasing stress, and sometimes it's not fancy, and sometimes people are wanting you to give them so much more, and it's like, let's start here. Let's start, doing these simple foundational things. What do you think about these combination thyroid supplements with all these different combos in it? Like, I've had patients ask me that, can I just take this with all the different things that support your thyroid? And I usually don't think that's a really good idea.
No, I think it's a bad idea for most people, because if your issue was you're just selenium deficient, then why don't you just take selenium, right? But that's not the case for most people. They're not necessarily selenium deficient. If they have an immune inflammatory process going on, maybe they're diverting the selenium to deal with the inflammation, the oxidative stress. Maybe that's where it's going. So, like what we were talking about earlier is, we assume that if we just put stuff in, it's going to do what we want it to do, medications and supplements, but they don't always do what we want them to do. You're talking about mitochondria. Well, the hot thing is everybody's got mitochondrial dysfunction. Do they? Or is their mitochondria down-regulated because there's an immune inflammatory or a cell threat going on? So, and I'm sure you may have talked about this before in your podcast. What we do is we bring glucose and fats and fuel into the cell. Then we drive it into the mitochondria, and the mitochondria take food energy and turns it into cell energy through this oxidative, oxygen-rich process that makes cell energy. The stuff we call ATP, adenosine triphosphate, the stuff you learned about in 7th grade science class. The process of turning food energy with oxygen into cell energy produces some waste, some exhaust. Just like your car, driving the car produces some exhaust. The cool thing about the cell, even though that cell is making some oxidants or free radicals as part of that process, the healthy cell also makes stuff called antioxidants, which then are typically you make some oxidants, and then the cell makes antioxidants, and all is good and right in the world, and there's no problems. However, I think almost everybody who has some type of cell stress response on has an adaptive downregulation of their mitochondria, not by accident, not by broken physiology, but because of an adaptive response. Because what a cell does that's perceiving stress or danger is it increases free radicals to help kill the threat. It's mixing some toxic things inside the cell to try and kill whatever the threat is. Organism, deal with a toxin, whatever it is. And if you have the full load of exhaust, free radicals, oxidants being turned out by a full tilt running mitochondria, and you have these free radicals being generated because of the stress response, what would happen to the cell is it would make way more free radicals or oxidants than it can make antioxidants. And what would happen is you would damage and destroy the cell. You kill the cell. So what the cells do adaptively when there's a cell stress response is they reduce that conversion of T4 to T3 that down regulates the mitochondria, not because it's broken, because it's trying to say, whoa, we're in low manufacturing mode. Let's slow the mitochondria down. We'll have less free radicals formed, and we can use this antioxidants that we make to really support the free radicals that we need to kill the threat, and we won't damage the cell in the meantime. But I think a lot of people don't realize that. So what do? They say, I'm going to give you this mitochondrial formula. I'm giving you CoQ10. I'm going to give you all this stuff. But then they're surprised it didn't work. Well, why would it work? Mitochondria doesn't really need them. Everybody's giving CoQ10. In lab studies, when they check people who have hypothyroidism, cellular hypothyroidism going on, they already have high levels of CoQ10 in the cells. Why? Because they don't need it. They're not using it. So that it's already high. That person doesn't need more. They're already not using what they got. That's not broken physiology. It's adaptive. So we should expect almost everybody has a down regulation of their mitochondria. We should expect everybody in those situations to have some level of glucose resistance. That's not often broken. It's adaptive, at least in my opinion.
Well, what do you, I thought one thing I thought was really interesting hearing you talk about the importance of how we breathe and disordered breathing. Can you talk about that? I was telling my husband, like, he was talking about taping your mouth. He was like, what?
Yeah, so cells generally run most efficiently on oxygen. Where do we get our oxygen? We get it from the air we breathe. We breathe in oxygen. We blow out carbon dioxide. Oxygen gets bound to the red blood cells, and the red blood cells carry oxygen all over the body. That oxygen then needs to get released from the red blood cells, get to the cells. Cells bring in the oxygen, and now they can run the machinery. So when we don't breathe appropriately, especially when we do a lot of mouth breathing, we blow off too much carbon dioxide, and we wind up having too much carbon dioxide in the bloodstream. And that can happen because we don't breathe well. It can also be because we have acidosis in the body, and now we're using the carbon dioxide to buffer systems. The only reason that red blood cell is going to give up the oxygen is if there's carbon dioxide available. So if I'm breathing out through my mouth all through the night, then I'm blowing off too much carbon dioxide. I drop the carbon dioxide levels in my bloodstream. My red blood cells won't give up as much oxygen. Now my tissues have less oxygen, and less oxygen in the system then triggers that danger physiology. And now the body, those cells and tissues are going to reduce the conversion of T4 to T3. That's going to slow your metabolism down. That's going to lead to more calories being stored, and you're going to gain weight. So I've turned down the metabolism, at least at the cell and tissue level, and I'm going to start gaining weight just because I'm not breathing appropriately. So what do? You go back to the way we're meant to breathe, which is primarily through our nose. But yeah, what are strategies? Almost everybody's got some chronic inflammation. They lay down at night, their nose gets stuffy. They don't even realize it. And while sometime in the middle of the night when they're asleep, they can't breathe through their nose. They open their mouth. Everybody says they don't breathe through their mouth. Nobody snores. Nobody breathes through their mouth. Yet cavities are a problem. Teeth grinding is a problem. Hypoxia, sleep apnea is a problem. But Chronic inflammation narrows the passageways that makes it more difficult to breathe, and therefore that can be a huge factor that's triggering somebody's weight gain, their reduced metabolism, and their hypothyroid state.
And for women, as we, go through that menopausal stage, unfortunately, insulin resistance tends to creep up. Unfortunately, our tolerance for stress decreases. There's a lot of different changes. And chronic inflammation, I think even just aging itself can lead to inflammation. So what do you say, well, especially with the insulin resistance, what kind of strategies do you often recommend? Because that is a big problem for a lot of women.
Yeah, I think insulin is like the redheaded stepchild of the hormones, right? It gets all the blame for being a problem. But cells under stress become glucose resistant. There's 4 hormones to raise glucose. There's only one to lower it, that's insulin. And so if you're not breathing appropriately, if you've got stress and inflammatory mechanisms going on, and you're down regulating the conversion of glucose into through oxygen inside the mitochondria into ATP, then you're up regulating these other hormones on a chronic level to increase glucose, which then needs to get into cells and tissues. And to get glucose into a cell or tissue, you need T3. T3 drives the glucose transport mechanisms, both insulin dependent and insulin independent. So T3 is required. So I think the big reason why we see more inflammation as we get old, or more glucose resistance in people as they age, is because they have more inflammation going on. For women, especially if they're estrogen physiology, if they don't have enough estrogen, because estrogen is critically important. Estrogen helps support and run and drive the mitochondria. So we don't want too much estrogen, but we need some to support the mitochondria. So when you go into that second phase of life, is if that cellular physiology, especially that adrenal production of androgens and then the conversion of androgens to estrogens isn't very good, then your cholesterol is all sitting in your bloodstream instead of getting into the tissues, and you're going to have low estrogen. At the cell level, you're going to have decreased mitochondrial function, right? And so what do? If you have decreased mitochondrial function, you're not going to be able to burn more glucose. You're going to have to keep pushing excess glucose into fat storage. So what do I recommend? The first steps are very simple, which is, it's something everybody can do. Everybody should really focus on primarily 85% of the time, a whole food diet that's 40% protein, 30% fat, 30% carbs as a starting point. You may tweak some of those numbers, but that's where you should start. Because if you're doing that and you're doing some level of physical activity on a daily basis, your issue isn't excess carbohydrates and lack of activity. So you can, when your doctor tells you that, you can say, go scratch, you don't know what you're talking about. Most doctors don't ask, what's your calorie and macros and what's your physical activity? They just see glucose or insulin resistance or pre-diabetes or diabetes and assume that you're not doing anything. But if somebody is doing that and they still have glucose resistance, then the next thing we have to ask is what's creating that stress response. So we look at what I call the fitness factors in my book, which your dietary fitness we just kind of talked about, but what's your emotional fitness? What's going on between the 6 inches of your ears that's creating a stress response? Because if you've got a lot of conscious or subconscious stuff going on that's creating stress, then it's increasing your sympathetic nervous system. That's going to increase glucose production via cortisol and catecholamines, and that's going to create an issue or a problem. If they also need to look at their breathing and which we just talked about, what's going on with their sleep physiology. Then we take a look at their habits, their behaviors, their workout. Is it appropriate for what they're doing? And then we start to look at the organs and the organisms and the systems to say which systems may be contributing to the problem. But something is driving the glucose resistance, because if we go back to the really simple concepts of how physiology and metabolism works, when we consume more calories than the body needs, then we start storing extra calories in fat cells. And then the fat cells release leptin. Leptin goes to the brain, and that leptin in low levels at the brain increases the stimulation and drive for more thyroid hormone and improves the conversion of T4 to T3 that turns on the metabolism, and we burn those reserves back down. That's why some people seem to eat whatever they want and maintain their body weight. There's no problem. When physiology is being negatively impacted by stressors, then what happens is we've had decreased conversion of T4 to T3. We have that cell stress response going on. More food energy is being diverted away from energy production towards fat storage. Fat cells are releasing leptin, but the leptin, because of the inflammatory response, isn't allowing for that better conversion because of the cell stress response. And so then what happens is more calories get stored in the fat cells, more leptin gets produced. The physiology is not working, so more gets stored. And eventually leptin gets above about 20, and now the brain becomes leptin resistant. And so now that person who's, even though they're overweight and they just ate, is like, I'm still hungry. And they continue to eat, which they can't get those calories into the cell, and it promotes more fat storage. And this becomes the vicious cycle. So we have to be aware of not that it's just calories in, calories out, but more times than not, what's causing us to be overweight is the result of some type of stress response at the tissue due to diet, lifestyles, thoughts, habits, behaviors, toxins, whatever it is. And the only professional that's really focused on that truly is the quality functional medicine practitioner. That's not the allopathic physician's job. We have to stop pretending like it is their job. Their job is to acute care, crisis care, surgery, and disease management. It's not what we do. They can do what they want to do. We can do what we want to do. And if we can build a bridge between the two, we can all live well together without bashing each other. But they don't do what we do. We don't do what they do. But we also have to educate the patient that if you don't want to do anything to change your diet, your lifestyle, your habits, your behaviors, your emotions, then you need allopathic drugs and surgery. But you're not going to ever be healthy. If you are willing to change something in your habits, your behaviors, all these things, then you want functional medicine, because that's what we do. And you can not only need less and less medication, you may not need any at all, and you can restore your health and your well-being. That's healthcare. What most people are going to is a disease care model and hoping they're going to get healthcare. That's like asking my plumber to run the wiring in my house and coming home and finding out I've got plumbing everywhere in all my outlets, right? It's craziness.
Well, thank you so much. I know you got to get out of here, and just thank you for spending this time with me. And if you don't mind, just share real quick about your book that you have out and your podcast and where everybody can find you.
Sure. My book is called The Thyroid Debacle. I wrote it with a good friend of mine, Kelly Halderman, former MD. So she was in that world and came to functional medicine. So the book is written in 3 parts. The first part of the book is written from what she learned in med school and what your medical doctors essentially taught. And so she wrote that part to kind of help somebody understand, this is how I was taught, this is how it is. So you understand why they do what they do, and they don't do what you want them to do. The second part of the book is where I really break down what's going on with the chemistry, and it gets pretty heavy and into a lot of the stuff we talked about today, trying to help somebody understand what's happening at the cell level, help them understand how to look at labs and how to interpret labs. And it can be a bit heavy, but that's really what we want to do in functional medicine, is have an educated patient who can take care of themselves, can start to look at things and maybe not understand the depth and breadth that we may know, but you got to have at least start hearing this stuff, because if you didn't know there's something called T3 and free T3, and those things are what's actually supporting the cell, how would you know that you're something else? You wouldn't know. And then the third part of the book is really about what we call those fitness factors. What are the diet and lifestyle factors that you can start to evaluate and address on your own without the help of somebody like me? Because I'm sure for you, just like me, when somebody comes in, these are the things you have. Hey, what's your diet? Are you eating a whole food diet? Like, what are you eating? What's your sleep? What's your breathing? Like, these are all the things we're going to talk to you about anyway. None of them are sexy, but you don't really need a paid professional to assess those things. You just need to start working on them. So that's what the third part of the book is about. What's not in the book is a list of all the supplements that you could take to manipulate these things. Because I'm not a supplement. I mean, I use them, but I think too many people default to boatloads of supplements to try and to deal with their issues versus drugs, and they think that's functional medicine. That's greenwashing of allopathic medicine. It is not what functional medicine is about. Supplements are a tool, but not the tool. There's not enough supplements in the world to supplement yourself from sick to healthy. It just doesn't. There's no magic pill. I don't care what somebody says with their thyroid, support formula. There's no magic there. The magic is in changing habits and behaviors and everything else. For the podcast, my podcast is called Thyroid Answers Podcast. And it's answering a lot of the questions that people have day in, day out. We have some great interviews. At some point, maybe we'll have you come on the podcast and talk about hormones. But that comes out at least twice a month. And then my website is, and my YouTube channel are places where people can go. Probably, I'm not a social media person, but I put stuff out on social media, but Instagram is probably where most of my stuff is.
All right. That's kind of how I started following you and listening to your Thyroid Thursdays that are awesome. So
yeah, so those aren't the TikTok fancy videos where like little things pop up. Those are cute, but I don't dance. I'm part Polish, so the top and the bottom don't move together. And my goal is not to be cute or fancy. My goal is really to try and help educate. So that's what those are about. I've had people say, you should do TikTok. Look, that's not me. It's not me. That could be somebody else. It's just not who I am. But I want you to, it's on my whiteboard is, here's the lab interpretation. If you got these panels, when should this person get more thyroid hormone? Somebody asked that question. I'm like, okay, let's take a look at 3 different sets of labs of thyroid panels. Which person needs med, which person has enough, and which person needs less medication. That's what I want to do with those Thyroid Thursdays. So hopefully, if you started watching them and you got value out of it, then I think I'm on the right track.
Well, thanks again for being here. And I will link everything to you. And I just really appreciate your time. And I've learned a whole lot. So thanks again.
You got it. Thanks for having me on the podcast.
Thank you for joining me on the Midlife Wellness NP podcast, where we explore the various aspects of women's health during the menopause transition. I hope you found today's discussion insightful and empowering. Remember, your well-being is a priority, and I'm here to support you on your journey to a healthier, happier, and fulfilling midlife and beyond. Stay tuned for more engaging conversations and valuable insights. Wishing you good health and wellness until next time.